go into it is by one of our own, Dr. Larai Aliyu Tambuwal, Executive Director of Sussex State Primary Healthcare Development Agency, who will be presenting another sub-theme for today's AGM, which is revitalization of primary healthcare as cornerstone to achieve universal health coverage. Please permit me to invite Dr. Larai Aliyu Tambuwal. Our former teacher was here as a keynote speaker. Imagine a teacher. It's an honor to have both of them here as our speakers.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم وصلى الله على النبي الكريم. My elders here present, Prof. Tawfiq Ibrahim, Babana Sarki Bodinga, my other seniors here present. Kindly pardon me, let me stand on the existing protocol, and I hope it will not break as many of us are standing on it. Yes, I'm not that good in protocols, but I'll try. I want to greet you with the Islamic greeting, Assalamu alaikum wa rahmatullahi wa barakatuh. I have the honor and privilege to stand before you today to talk on a topic that is thought-provoking. It is a pity that I have to speak after my prof have spoken. He must have discussed everything even before I arrived. But I will try to showcase that I have also been trained by him. The theme before us today, revitalization of primary health care as the cornerstone to achieve universal health coverage, could not have come at a better time. It strikes at the very heart of Nigeria's health system challenges and opportunities. Primary health care, as we know, is not a new concept since the declaration of Alma-Ata in 1978. The world have continuously recognized PHC as the foundation of effective, equitable, and sustainable health system. But yet, nearly 5 decades later, our country, Nigeria, still grapples with weak PHC structures, fragmented implementation, and inequitable access to care. But today, as I stand here, I'm not just here to highlight the problems. Prof have already itemized them, and he has so extensively explained them. But I'm here as part of the team to echo the renewed call for revitalization. That is to breathe life back into our PHCs so that they can serve the purpose and stand as the true gateway to universal health coverage. Why does PHC matter? Primary health care matter in that, as colleagues, we have to remember that 70 to 80% of Nigeria's disease burden can be effectively addressed at the primary health care centers through immunization, maternal and child health services, family planning, nutrition, health education, and basic curative services. They are the closest to our people, especially in rural, hard-to-reach, and underserved communities. A functional PHC system reduces unnecessary pressure on the secondary and the tertiary facilities, allowing the specialists to care for more advanced cases. Simply put, without strong PHC, universal health coverage will remain a dream and a mirage. Universal health care coverage is the concept of ensuring all people, regardless of their income, social status, or geographical location, can access quality health services when they need them without facing financial hardship. It is more than just about access to care, it is about having comprehensive services that are affordable, equitable, and effective. So the key elements, equity is The first, every person, especially the marginalized groups, those living in the underserved, hard to reach, and even security compromised areas, rural populations, they must have access to healthcare without discrimination because the diseases they suffer, they are not different from those ones that we suffer in the metropolis. Then the health services must be comprehensive to include preventive, curative, rehabilitative, as well as palliative across all the levels, primary, secondary, and tertiary levels of care. There must be financial protection, ensuring that people do not face catastrophic costs when they seek health services. This is often achieved through health insurance, public financing, taxes, national health schemes. So why is it important? Prevention and early detection of cause, and that is what it entails, to emphasize on preventive care, reducing the need for more expensive care later. Economic stability. When people can access affordable care, they are more healthy and they remain productive and they continue with their economic lives. Social justice. Universal health care coverage is a fundamental human right. It is not a privilege, but a right that must be given to ensure security and peace of mind. In the area of health system resilience, countries with universal health care coverage are generally better prepared. When the COVID came, Nigeria and Sokoto in particular, we were not prepared and we grappled and many people died as a result of the weak health systems. So one of the challenges that we face is financial resources. We have to ensure adequate funding for health services, especially in low-income countries. Sometimes you find that there isn't even a budget line for some of these PSC services. And whenever the budget line is available, they don't get approved or released timely. And when they got released, people find their own way to divert them for their own selfish activities. The healthcare infrastructure, building and maintaining functional healthcare system, especially in rural underserved settlements and communities. In Sokoto, most of the primary healthcare facilities, I can say maybe when this government came on board, we found more than 40% of them dilapidated. Some of them, they are just there as structures without any equipment, and whenever even the facility is there, the staff are not there. We find some of the facilities do not even have one community health extension worker to offer the services to people there. Lack of trained professionals. We have a lot of turnover of the PSC workers. Most of those that have been trained earlier, they have been interchanged due to politics. And the people that have been brought to replace them do not have adequate training. That is one of the problems. So the capacity is not there to offer the services as they are needed. Governance is also faulty. The policy frameworks are there. Sometimes the House of Assembly, they make those policies. The ministries and agencies translate them into programs and activities, but the implementation get bottlenecks and the policies remain not implemented. For Nigeria or similar context, achieving universal health coverage requires revitalizing PHCs as a key strategy, because PHCs, they are the closest and they can offer simple services that could take care of a lot of problems. In simple terms, universal healthcare coverage means that healthcare is available, affordable, and accessible to everyone, including the most vulnerable populations, the disabled, and the marginalized. The current realities, I'm sure Prof have shed light on some of the indicators. I want us to know that over 30,000 PSCs in Nigeria, less than 20% of them are functional, meaning that the resources that are needed to run those facilities, to offer the services required, they are not adequate in the area of human, the material, and the monetary aspect of it. In Sokoto, we have about 833 health facilities under the Primary Healthcare Development Agency, about 447 PSCs, 115 health clinics, 271 health force. Out of them, about 244 have been prioritized and made functional. That is one functional facility per ward in our 244 political wards, so that there can be the primary referral center from the other PSCs, so that they can offer these comprehensive services. But when we assess them, like I told you, we found out more than 40% of them are not functional. So gaps persist in infrastructure, human resource, essential drugs, supply chain management, and financing. In many rural areas, women still deliver at home. Children miss vaccinations, and preventable deaths occur because the PSCs fail to deliver. We have a lot of outbreaks of vaccine-preventable diseases because the services are fragmented, and when they are even provided, the community members also have their own factors, the barriers that prevent them from taking those services. They do not come to the facilities. When they are visited even within the communities at their houses, they refuse these services for various reasons. A number of barriers, like I said, traditional, religious, and attitudinal were also found to affect the status of our indicators. This is not just a health issue, it is a moral issue. Revitalization is the way forward. Revitalizing PSCs is possible, and it requires deliberate, multi-sectoral action. First of all, infrastructure and equipment. Every ward must have a functional PSC, well-equipped and accessible, providing 24/7 essential services. Well, revitalization has started. In 2024 budget, Sokoto State have included in the budget to renovate 244 facilities, one per ward, to ensure one functional facility. It is going on, but piecemeal. It is not holistic. And also we have some donors and some philanthropic individuals coming in to support the system. We have the World Bank project, that is the impact project, revitalizing about 116 facilities, and it is ongoing. And it is part of that revitalization to also purchase equipment as well as essential drugs and to support immunization services. Then we have the World Bank Padama project also, revitalized and renovated about 18 health facilities, different from the one that Impact are revitalizing. Then we have the Basic Healthcare Provision Fund, which is from MPSCDA Gateway, supported the revitalization of about 5 health facilities, which have been concluded and they are about to be handed over to the local governments to continue. And we have a lot of donor agencies and partners, like Plan International, International Rescue Commission, and other donors that are also revitalizing. And we have individuals also revitalizing some of the PSCs, and we are bringing documentation to the PSC agency so that we can know the proportion that have been revitalized and so that we can know where we are. Human resource for health, recruitment, fair distribution, training, and motivation of health workers are critical. Task shifting, incentives for rural services, and digital solutions can bridge the workforce gap, just like my brother has said. In the area of recruitment, in 2024, the State Ministry of Health recruited about 800 nurses and midwives and posted them to various health facilities, including secondary facilities. At the Primary Healthcare Agency, we have done about 3 recruitments, including community midwives, CHUs, SCHUs, JCHUs, and in some areas, nurses and midwives under the Basic Healthcare Provision Fund. About 90% of them, they are being taken care of by Basic Healthcare Provision Fund. And they have been distributed to various facilities to provide services and bridge some of the gaps. And as well, this year, we have about 420 graduated from School of Health Technology, Guadabawa, and we are in the process of enrolling them, screening them, and also employing them to go on to these PSCs and offer the services. In the area of training, yes, a lot of donor agencies have been doing training for our staff. But also from the federal government through the SWAP initiative, last year we were able to train about 1,200 frontline health workers who are working at the primary health care centers, and also we are about to train another batch this year just to improve their capacity so that they know how to treat these cases and offer the services that are needed so that we leverage on it to reduce the burden to the secondary facilities. And the Honorable Commissioner have just defended a memo at the Council to allow redistribution of health workers from the central, from the metropolis, because everybody now wants to stay in the metropolis, nobody wants to go to the rural areas. You find some facilities with just one health worker doing everything. So it is about to happen. The redistribution is going to take place so that all the facilities where services are needed, there will be people to take care of those services. Financing and sustainability. There's need for us to move from donor dependency to domestic investment, budgetary allocation for the PSCs to be protected, released, and tracked to ensure accountability. Like I said, the state has its budget on some of the items in the annual operation plan, but not always. And we suffered it when Mr. Trump withdrew some of the support that was given through the USAID, and some of the thematic areas could not find funding. But Alhamdulillah, His Excellency took it upon himself. He provided funding, counterpart funding, or matching funding for nutrition services, for family planning services, as well as the PSC MOU, which is used to fund routine immunization and other PSC services. As well, we get funding from the not less than 1% consolidated revenue, which is the MPSCDA gateway, and that is what we use to provide financing directly to the facilities, to be able to purchase essential drugs, to be able to recruit human resource for health, and to be able to conduct some minor infrastructural repairs so that they can also partake in the revitalization of the PSCs. As well, we have the CHIPS program, that is Community Health Influencers program, that is going into the communities to mobilize, to create demand so that people come and access these services and do not allow them to be wasted at the facilities. Technology and innovation, community ownership. We have also realized that this work will not be good and the problems will not end until the traditional, the religious, and other grassroots members partake. Usually when we go to the communities, we just go ahead and continue to do our services, and those people are watching us. They do not know what we are doing, they do not understand us. But now that when we invite them and include them in the planning, in the implementation as well as evaluation of those services that we render, they now feel involved, they take ownership. My father, Sakin Bodinga, is here. Whatever we do, inshallah, he has always been part of it, and he has been a great advisor and mentor in that respect. And we are seeing the better of the services today, even though we are not yet there, but the system is improving gradually, inshallah. Then partnership with government alone cannot revitalize the PSCs. We need strong collaboration with professional bodies like Nigerian Medical Association, developmental partners, civil society, traditional leaders, and the private sector. We need more coordination and collaboration because Sokoto State is blessed. We have more than 50 partners supporting the health system. But the coordination is poor, and that is why a lot of investment, a lot of resources are being sunken, but the results that are coming out, they are not commensurate to the investment that is making. So we need, I attended a session in Ogun State last month, and somebody questioned the professional bodies that when you see data coming out of primary health care, when you see data coming out of state ministry, query that data. Query the data, let it be validated, so that we also, we are at home with our own values. When the Honorable Commissioner newly resumed duty, he asked me about maternal mortality. I said, sir, in the whole country, we are still using the 2020 figure. We don't have the recent figure. I said, okay, but let me show you the one that we have for the state, the DHIS. And then when I now did the analysis, we saw 382 or 83. as our own maternal mortality rate. If going by that, Sokoto is home and high, but we all know that it is not like that. And the national figure remains more than 500. So we need to validate. We need to have somebody oversee whatever we submit, so that we don't just submit rubbish into the system. And this work cannot be done by primary health care development agency that is implementing the activity. We need an external force to come and say, why are you writing this? Is it true? Is it valid? So that we know. And when I go to national, I argue a lot that in Sokoto, my DHIS to routine immunization is 69%. They say, no, you are 8%. I said, sir, I do not agree on 8%. Because there should be congruency in the data source. In 2016, Sokoto was termed as having 3.4% routine immunization coverage. Then in 2022, we moved to 12%. And now this year, or last year, 2020, 2024, they are telling me I am 8%. How can I be going back retrospectively? I cannot be doing that. But they use NDHS, National Demographic Health Survey. If you are using mixed NICS in 2016, mixed NICS in 2022, also use mixed NICS in 2024, so that I will see my own trend. If I'm going down, I will know. But you cannot use mixed NICS, and then you now use NDHS to, how can I even take that? So we need this backing from NLA and other professional bodies to come and put eye on us and say, what are you submitting? So that whatever goes out of Sokoto, we know that it is a true figure. Because if going by our own DHIS 2, Sokoto is having about 382 maternal mortality rate. And that is below the national average. So, but we want validation. You are advocates. As frontline doctors, you are the bridge between policy and practice. You can assert your way. You can question anybody so that the truth be told. You are advocates who can influence policies for stronger PSC system. I know before the beginning of this administration, I know there was a move to have the NMA review the policy, the health policy. But I think it was truncated at some point. NMA, please come back to the table. Let us bring the health policy, let us validate it, let us review it, and then inculcate other things that were not there before. Before, the swab was not there. MAMI project was not there to reduce maternal mortality. And the basic healthcare even provision fund was not even there. Impact project, all these projects and programs, they are not there. Let us capture them into the recent reality for the policy so that we know what we are talking about. You are mentors to young health workers and role models in your communities. You can influence them to do good, to do right. We cannot achieve universal health coverage without the enemy as a committed partner in this revitalization agenda. Ladies and gentlemen, the dream of UCH is not utopia. It is possible, achievable within our lifetime, but the path is clear. We must strengthen and revitalize the PSC system. Let us remember that a health system that neglects PSC is like building a house without foundation. It may rise, but it will not stand for long. It will crash. Together, let us lay a strong foundation. Together, let us make PSC the cornerstone of UCH and USC in Nigeria. Together, we can guarantee that no Nigerian, regardless of location status or social status, is denied the right to quality health care. I thank the leadership of the Nigerian Medical Association Sokoto chapter for the honor of delivering this address. May this AGM be remembered as a turning point where we collectively renewed our commitment to revitalizing PSCs. Primary Healthcare Development Agency, under the State Ministry of Health, we cannot do it alone. Everybody have to come and support us. We are waiting for you. Thank you very much.